Hello, everyone. So in week 12, we are returning briefly to psilocybin before we move on to ketamine in week 13, and then finish up the semester with just some things to think about ethically and directions of this field. So let's talk about addiction for a second here. So potentially at first glance, the reading that was included in this week may feel kind of out of place in a week focused on palliative and existential care. However, it actually provides a crucial conceptual bridge for us. So the author of this chapter reframes addiction not simply as a chemical dependency, but as a pattern of constriction, a narrowing of behavioral and psychological flexibility. Individuals become stuck in repetitive cycles even when those cycles are harmful. So, if we zoom out, this is not fundamentally different from existential distress. In end of life contexts, individuals can become stuck in rigid narratives such as, my life had no meaning, or I am only my illness, or death is only something to fear. So, what connects addiction and existential suffering is not the content, but the structure, its rigidity, its repetition, and its narrowing of possibilities. Psilocybin appears to intervene at this structural level. So, the reading begins by grounding us historically. During the early era of psychedelic research, there was already significant interest in addiction treatment, particularly with alcoholism. Over 1,000 studies and tens of thousands of patients were involved, which is striking given how new this field is often portrayed as today. Initially, researchers thought psychedelics might work by mimicking delirium tremens. We've talked about this before, a severe and sometimes life-threatening withdrawal state that occasionally led people to stop drinking. However, what they actually observed was something very different. Rather than inducing distress, psychedelics often produced mystical type experiences, feelings of unity, transcendence, and deep insight. These experiences appeared to catalyze meaningful behavioral change, including reduced alcohol use. This is our first major paradigm shift. Addiction treatment may not be about suppressing craving directly, but about transforming the person's relationship to themselves, their life, and their behavior. One of the most important takeaways from this reading is that subjective experience matters. So this is a repeat of weeks 9 and 10, right? Or no, 8 and 9 maybe. In most medical models, the subjective experience of the patient is secondary. Here, it is central. The intensity and quality of the psychedelic experience, particularly mystical type features, are strongly associated with outcomes. This suggests that the treatment is not just the drug, it's the experience the drug facilitates. From a relational perspective, we might think of this as a reorganization of meaning. Clients are not simply reducing substance use, they are encountering themselves, their lives, and their relationships differently. The author explicitly contrasts psychedelic therapy with traditional psychiatric medication. Most medications require ongoing use and primarily aim to manage symptoms. Psychedelics, in contrast, are used sparingly, often 1 to 3 times, and appear to produce lasting change. This suggests that the mechanism is not pharmacological maintenance, but learning. Psychedelics may create a temporary window in which individuals can learn something new about themselves, their behavior, and their world. This is a fundamentally different paradigm and one that aligns closely with psychotherapy. The concept of plasticity is central. Psychedelics appear to induce a temporary state in which rigid patterns loosen. This applies to behavioral patterns like smoking, cognitive patterns like self-criticism, and emotional patterns like avoidance. From a systemic perspective, we might think of this as an interrupting a feedback loop. Once the loop is disrupted, there is an opportunity for new patterns to emerge. This becomes especially important in existential work, where clients may be stuck in rigid narratives about death, meaning, or identity. The author makes a fascinating argument about tobacco addiction. Unlike alcohol or opioids, tobacco does not typically cause immediate life chaos. People can function relatively well while smoking, sometimes for decades. This makes it what's considered a pure model of addiction, a conflict between short-term reward and long-term harm. The question becomes, can psilocybin help individuals resolve this conflict even when there is no dramatic rock bottom? This is highly relevant to existential work. Many existential struggles are not driven by crisis, but by subtle, long-term patterns of avoidance or disconnection. Participants in this study were highly treatment resistant. They had been smoking for decades and had already tried multiple methods to quit. The treatment combined CBT with psilocybin sessions, which is important. The psychedelic experience was not standalone, it was embedded within a structured therapeutic framework. The first psilocybin session occurred on the target quit date, which likely increased its psychological salience. The outcomes were striking. These rates far exceed those of standard smoking cessation treatments. But again, the mechanism is key. Those who had more intense mystical type experiences showed better outcomes. This suggests that the depth of experience matters, not just the intervention itself. Participants described profound shifts, not just in behavior, but in identity and worldview. They reported feeling more connected, more curious, and more engaged with life. Smoking was no longer simply a habit, it was something they could see, understand, and choose differently about. This is where we begin to see overlap with existential and palliative work. The intervention is not just about stopping a behavior, but about transforming one's relationship to life itself. The findings extend beyond tobacco. Participants in opioid studies described LSD as forcing them to face themselves, in contrast to heroin, which numbed them. This language is deeply existential. It speaks to confrontation with self, truth, and meaning. In cocaine studies, psilocybin is associated with increased life satisfaction and reduced stress, suggesting broader psychological benefits beyond abstinence. So, this is a critical point. Difficult experiences like fear, grief, even death related imagery are not necessarily adverse. In many cases, they are where the most meaningful work happens. This aligns strongly with experiential and EFT approaches. Transformation often requires moving through difficult emotions, not avoiding it. So the author ends with a provocative idea. Addiction may be a special case of a broader phenomenon, pattern rigidity. This reframing allows us to connect addiction to other conditions like depression and anxiety, which also include repetitive, self-reinforcing patterns. Psychedelics may function as pattern disruptors, temporarily loosening rigid structures so that new possibilities can emerge. This is highly relevant for existential distress, where individuals may feel trapped in fixed meanings about life and death. So for MFTs, this work is inherently relational. Even when the experience is individual, its meaning is constructed within relational patterns and systems like family, culture, and identity. So your role is not just to support behavioral change, but to help clients integrate these experiences into their relational world. And moving to the next reading, moving on to some articles here. So psilocybin for depression and anxiety and life-threatening cancer. So this study begins by situating us in the reality of cancer care. A substantial portion of patients, up to 40%, experience clinically significant depression or anxiety. But importantly, this distress is not just psychiatric, it is existential. Patients are confronting mortality, uncertainty, loss of identity, and disruption of meaning. Traditional treatments like antidepressants, benzodiazepines, and even psychotherapy show limited or modest effects in this population. This creates a major gap in care. From an MFT perspective, this distress is also deeply relational. Patients are navigating shifting roles, dependency, anticipatory grief, and changes in how they are seen by others. Psilocybin is uniquely suited for this context because it operates in domains that traditional treatments struggle to reach. Rather than simply reducing symptoms, it appears to shift how individuals relate to their life story, their relationships, and their impending death. This is why existential therapies have also shown promise because they engage meaning directly. Psilocybin may accelerate or deepen that process. So, this is one of the most rigorous psychedelic studies to date. Participants received both a low and high dose in counterbalanced order. This design helped control for expectancy effects, which are especially important in psychedelic research, as we know. The study also included long-term follow-up at 6 months, which is critical for assessing durability. So this is not just a drug trial, it's a therapy model. Participants spent hours in preparation and building trust with monitors or their guides. During sessions, they were supported by not directed, they were supported but not directed. They were encouraged to trust, let go, and be open. That was the tagline of our study. Um, the environment was intentionally designed to feel safe and not non-clinical. From an MFT lens, this is a relational container. The therapeutic relationship and the broader holding environment is central to the outcome. During high dose sessions, participants experienced significant alterations in perception and emotion. Importantly, both positive and challenging experiences occurred. They experienced joy, peace, and connection, and they also experienced anxiety, fear, and distress. These were transient and resolved within the session. The presence of trained monitors or guides allowed participants to move through these experiences safely. So the results are striking. A large majority of participants showed clinically significant reductions in depression and anxiety, and these effects were sustained at 6 months. To put this in context, these rates far exceed typical outcomes for both pharmacological and psychotherapeutic interventions in this population. So this is where the study becomes especially relevant for this week. Psilocybin did not just reduce symptoms, it transformed existential orientation. Participants reported greater acceptance of death, improved sense of meaning, and improved coherence in understanding their life. This is exactly the domain where traditional interventions often struggle. One of the most compelling aspects of the study is that changes were not just self-reported, they were observed by others. Family, friends, and colleagues reported greater patience, more emotional openness, and increased compassion. So, from a systemic perspective, this is critical. Change is not isolated, it reverberates through relational systems. One of the most important findings, the mystical type experience, is that mystical type experience mediates outcome. This means that the quality of the experience, not just the dose, predicts therapeutic change. Even when controlling for intensity, mystical experience remains significant. Clinically, this suggests that we are not just administering a drug, we are facilitating an experience. Participants frequently describe the experience as one of the most meaningful or spiritually significant events of their lives. This is profound. In therapy, we rarely have access to experiences that patients rank at this level of importance. This may explain the durability of the effects. So, an important point here is that not all experiences are pleasant, and they don't need to be. Difficult experiences often involve confrontation with death, unresolved emotions, and existential fear. But within a supportive context, these experiences can be transformative. So we always need to remain critical in our thinking. This study involved a relatively homogeneous sample with a highly resourced intervention. It may not generalize easily to broader populations. So for MFTs, this work aligns closely with narrative therapy with reauthoring of meaning, EFT of emotional processing, and existential therapy discussing themes like death, meaning, and freedom. So your role is not just to guide behavior, but to help clients, patients, participants integrate these experiences into their relational and identity systems. So integrating these readings a little bit so we can connect the two. Addiction and existential distress may look different, but both involve rigid patterns, and psilocybin appears to disrupt those patterns and allow new meanings to emerge. All right, on to the next. So psilocybin for anxiety and depression and cancer. Another very well-known study that complements the study that we just talked about. So this study is often taught alongside Griffith's, the last study that we talked about, because together they form the strongest, early evidence. Sorry, they form the strongest early evidence base for psilocybin in cancer-related distress. What makes this important is replication. Different site, different team, slightly different protocol, but very similar outcomes. That consistency is what begins to move the field from interesting to credible. So Ross and colleagues explicitly center existential distress as a core clinical problem. They emphasize that this is not just depression, it includes loss of meaning, loss of purpose, and a desire to die sooner. Importantly, they note that there are no FDA-approved pharmacological treatments for this type of distress. This is a major gap and one that psychedelic therapy may uniquely address. This study has a very similar design to Griffith's, but with an active placebo, which is niacin. Niacin produces flushing and mild physiological effects, helping preserve blinding. The study lasted about 9 months total, allowing for strong long-term outcome data. So this is a clinically depressed population, many with advanced cancer, stages 3 and 4, which that's the last stage of cancer. 4 is the most severe. Most participants met criteria for adjustment disorder with anxiety, which is important clinically. This reflects real-world distress more than major depressive disorder alone. However, the sample lacks diversity, which is a limitation. As you can see, 62% female, 90% white, quite homogeneous. This study explicitly integrates existential psychotherapy frameworks into the intervention. This is critical for it's a meaning-making or a meaning-centered therapy. It's spiritual and existential exploration, and it's support for confronting mortality. This is not drug alone, it is a combined pharmacological psychosocial intervention. So the results mirror Griffiths. There was rapid symptom reduction, large effect sizes, and long-term durability. What's especially notable is the speed of change. It happened within days. This contrasts sharply with SSRIs, which may take weeks and often show weaker effects in this population. So this study goes even deeper into existential measures than the Griffith study. So psilocybin reduced loss of meaning, desire for death, existential despair, and it increased a sense of purpose, inner peace, and spiritual connection. This is exactly the domain traditional psychiatry continues to struggle to treat. So this is really nuanced and it's an important finding. Psilocybin did not necessarily reduce fear of death directly, but it improved how patients related to death. This aligns with existential therapy. So the goal is not to eliminate death anxiety. The goal is to transform one's relationship to mortality. So safety is one of the most important takeaways. There were no serious psychiatric events, no cases of addiction, and no prolonged psychosis. Transient anxiety or fear did occur, but was manageable and often meaningful within the therapeutic process. Again, we see the same key mechanism. Mystical experience mediates clinical outcomes. Even when controlling for intensity, the quality of the experience predicts change. This reinforces a major paradigm shift. The experience itself is therapeutic. So the authors also discuss potential mechanisms. There's changes in serotonin systems. It reduced the default mode network activity, which is linked to rumination, and it increased neuroplasticity. They compare psilocybin to ketamine, but note psilocybin's effects last much longer. We'll talk more specifically about ketamine next week. So participants reported and others observed changes in relationships, emotional openness, and pro-social behavior. So from an MFT lens, this is crucial. Change is not just internal, it restructures relational systems. So again, some limitations. Remaining critical that this was a small, homogeneous sample. It was a resource-heavy intervention, and it's hard to isolate the drug versus therapy effects. So this is not a quick fix. The power of this intervention depends on the therapeutic relationship, the setting, and integration afterward, the general message of this class. All right, so moving to our next reading, psilocybin-assisted group therapy for demoralization. All right, so this study represents a major shift in the psychedelic therapy literature because it moves beyond the dominant individual therapy model into a group-based format. While earlier trials like Griffiths and Ross established efficacy in highly controlled individual settings, this study begins to ask a different question. How might psychedelic therapy function within relational systems? The population is also important. These are older, long-term AIDS survivors, many of whom lived through the height of the epidemic and experienced repeated trauma, loss, and social marginalization. The study focuses specifically on demoralization, which is not simply depression, but a deeper existential collapse involving hopelessness, helplessness, and loss of meaning. Demoralization is a crucial construct in this paper and one that is often underemphasized in traditional psychiatric frameworks. It refers to a state of existential suffering characterized by a sense that life no longer has meaning, that one cannot cope, and that the future offers little hope. Importantly, individuals can be demoralized without meeting criteria for a major depressive disorder. In fact, demoralization is often more strongly associated with suicidal ideation than depression itself, particularly in mentally ill populations. From a systemic lens, demoralization is not just intrapsychic, it emerges in relational, cultural, and historical contexts. So, older long-term AIDS survivors represent a uniquely traumatized population. Many were diagnosed when HIV and AIDS was effectively a terminal diagnosis, meaning they lived for years expecting death while witnessing the loss of friends, partners, and community members. Even though HIV is now a manageable chronic illness, these individuals often continue to experience profound psychological distress, including PTSD, grief, and social isolation. This makes them an especially important population for studying interventions that target meaning, connection, and trauma integration. This is not a randomized controlled trial. It's an open label pilot study, meaning that all participants receive the intervention and both participants and researchers know what is being administered. The primary goals are not to prove efficacy definitively, but to assess whether this approach is feasible, safe, and worth studying further in larger trials. This is important for you to understand because the strength of conclusions we can draw is limited, but the study is still highly valuable in shaping future research directions. So the intervention is intensive and multimodal. Participants engaged in both individual and group therapy before and after the psilocybin session. Group therapy occurred twice per week and was based on supportive, expressive group therapy, which emphasized emotional expression, mutual support, and existential processing. The psilocybin session itself was still conducted individually, but within the broader container of the group. This hybrid structure is key. It allows for deep individual experience while embedding that experience within a relational system. The group therapy model is grounded in existential and supportive expressive traditions. It prioritizes present moment emotional processing, encourages members to engage authentically with one another, and explicitly addresses themes of death and loss. The authors also adapted the model to include mindfulness and self compassion practices, which served both as grounding tools and preparation for the psychedelic experience. From an MFT perspective, this is where the intervention becomes especially rich. The group becomes a microsystem in which meaning is co constructed. The primary outcome, demoralization, showed robust improvement from baseline to end of treatment and remained improved at the 3-month follow up. Most participants experienced clinically meaningful reductions, and many showed sustained decreases in demoralization scores. This is particularly important because demoralization is notoriously difficult to treat with traditional approaches. Participants also showed improvements in trauma-related symptoms and complicated grief, which aligns with the population's history of trauma and loss. Importantly, there was no evidence that participation increased substance use, and cognitive functioning remained stable. This helps address a common concern that psychedelic interventions might destabilize vulnerable populations. There were no serious adverse events related to psilocybin, which is consistent with the other studies in controlled settings. However, there were notable acute reactions, including anxiety, paranoia, and physiological changes, such as elevated blood pressure. In some cases, participants experienced intense psychological distress, including trauma-related flashbacks. These experiences were difficult but often meaningful within the therapeutic context and process. One of the more important contributions of the study is its demonstration of the therapeutic potential of the group itself. Participants reported that the group helped them feel less alone, reduced shame, and provided a space for shared meaning making. From a systemic perspective, this suggests that healing is not only intrapsychic but relational. The group becomes a site of co-regulation, witnessing, and identity reconstruction. The authors note that group therapy significantly reduces the number of therapist hours required compared to individual therapy. This has major implications for scalability and access. Psychedelic therapy is often criticized as being too resource intensive, and group models may offer a way to expand access while maintaining therapeutic depth. This is a clinically complex population with high rates of trauma, psychiatric comorbidity, and substance use histories. Some participants, particularly those with borderline personality features, had difficulty integrating their experiences within the group setting. This highlights the importance of careful screening, preparation, and ongoing support. As with any pilot study, there were significant limitations. The sample size is small, there's no control group, and the open label design introduces potential bias. Additionally, this is a very specific population, which limits generalizability. However, the study still provides important preliminary evidence and opens new directions for research. So this study expands our understanding of what psychedelic therapy can be. It suggests that these interventions are not only about individual symptom reduction, but about relational healing, community, and meaning making. From a systemic lens, this is a powerful shift. It aligns closely with the core values of marriage and family therapy, where change is understood as emerging within relationships and not just within individuals. Across these studies, we see a consistent pattern: rapid symptom reduction, sustained change, and deep shifts in meaning. But what the final study adds is that healing doesn't just happen within the individual, it happens between people, in relationships, in community, and that's where this work intersects most powerfully with our field.